So this is a patient who is around 18 years old, a male, has an history, sorry, it's 13 years old male with an history of facial trauma. 6 years back, since then, initially he had restricted mouth opening, but since last 2 years, he is unable to open his mouth. On examination, mouth opening was nil, cannot pass his finger. Fingers cannot be insinuated between the condyle and the triggers on examination, and diagnosed as bilateral temporomandibular joint ankylosis. So he was posted for bilateral condylectomy under general anesthesia. Now, what do you mean by temporomandibular joint ankylosis? Is primarily TMJ is an diarthrodial joint, synovial joint. So it has two joints which is in one single unit. And actually there are two articulating surfaces which are fibrous, which is covered by fibrous cartilage, and the functions as a single unit. Now, naturally, if one unit is infected or it's traumatized, the other component is also affected. So naturally, this can lead to a complete joint ankylosis. How much mouth opening does each joint contribute? Now let me tell you to the students. Now, these are short cases. Remember one thing: in short cases, you are not asked to take a detailed history. They'll ask you just the management, airway management of this patient, or the anesthetic management, not the airway management, but they'll be asking the anesthetic management in how do you proceed for an anesthetic management in this patient. So you need to cover up only those aspects which is related to anesthetic management. So at times they can ask you deviate from a bit here and there, but otherwise the anesthetic management is more important in these short cases. Now, you know that it has a hinge joint which is 2 to 3 centimeter and a sliding joint which is 2 to 3 centimeter opening. So overall, you have a 6 centimeter mouth opening, which is because of these two joints which work together. Now, what are the clinical features of temporal mandibular ankylosis? Now, very importantly, the patient is unable to open his mouth, and unilateral ankylosis can also cause a deviation of the same side. In severe cases, there is incomplete immobilization, means they cannot complete immobilization, and so patient cannot move his mouth, jaw. Naturally, there's a complete there's no mouth opening at all. So there may be abnormal forward protrusion of the mandible as the excess tissues occupies the space. So facial deformity could be there. So what physical clinical features are of your concern, or what anticipate associated problems the patient can have? So very importantly, the joint movement in all directions are all restricted. Facial asymmetry, hypoplastic and retrognathia mandible is there. So naturally, patient can have a bird face deformity. Dentition problem because the patient cannot chew. So the patient can have caries or abscess in the dentition. Patient can have obstructive sleep apnea because of increased airway obstruction. Because what happens, these patients, the bony structures they cannot grow because it's fixed. But the soft tissues, that is the tongue and the pharyngeal tissues, they can grow. And when they grow, they become relatively bigger in size in relation to the oral cavity. So naturally, when these patients sleep, the space which is there in the oropharynx, it's limited, and the patient they start having obstructive sleep apnea. And finally, in the long run, they can have cor pulmonale. So these are the problems which this patient can have. So your anesthetic considerations will be that this patient is difficult airway. He could be associated with obstructive sleep apnea. He's sensitive because of this sleep apnea. He could be sensitive to central depressant drugs. So sedatives will always be very cautious on this. Poor nutrition because he's not being able to take adequate food. So he's mostly surviving on liquid diets, and because of dental hygiene is very poor, so infections could be there. Post-operative maintenance of airway could be again a problem, and most importantly, these are all pediatric age group mostly. So that itself is a difficult age group. So why do these patients have increased airway obstruction? As I said, it is secondary to structural encroachment of the pharyngeal and the hypopharyngeal lumen, and hypotonicity of the oropharyngeal muscles could be one of the most important reasons. What are the stages when you face difficulties in maintaining airway? So naturally, these are all the stages, starting from stage 1, psychological preparation, difficult mask ventilation, difficult laryngoscopy and intubation, and you have all the mnemonics and predicted factors through which you can assess that the patient really has difficult intubation and extubation as well. So why should there be a difficult mask ventilation? Because the mask fit is not possible. They have a small and receding mandible, and the tongue always falls back. So jaw thrust is not possible. If the patient is being sedated, or if you induce the patient, naturally maintaining an airway with jaw thrust or head tilt chin lift is not possible. So you cannot lift the tongue, and that can cause obstruction. So face mask ventilation is always a difficulty, and you cannot put an Goodell's airway also because their mouth opening is not there. So they are all having a difficult mask ventilation. So why should there be difficult laryngoscopy intubation? There are battery of parameters which are there, which tells you that the patient can have difficult intubation and laryngoscopy and intubation. What would you like to use sedatives? Now, as I said, these people are very sensitive, so they to the sedatives, and so that is why your sedatives should be as limited as possible. And at the same time, they are being worsened with OSA, and you should limit your sedation as much as possible. How will you deliver anesthesia to this patient? Now, this is the place where you need to work. Now, awake nasal fiber optic guided intubation is the gold standard. That's the choice. And there is again an amboescope which has recently come through that with the help, which is again a sort of fiber optic system. You can use it, and then once you've intubated this patient, you can go with followed by general anesthesia. What are your other airway management options? Now, one option which we have, which when we were students and we were young consultants, we had option was the trach-light nasal intubation. Now, this was something which is a semi-blind technique, which is you're being guided, your tube is being guided with the semi-circumscribed glow right in front of the in the thyroid cartilage, which tells you that you're right in front of the larynx, and with that help glow, you can intubate this patient. So this is one technique, which is a semi-blind and technique. Then these are the other devices which are there, but blind nasal awake nasal intubation was once upon a time very much used, but in pediatric patients you should all be very cautious in it. Nowadays we don't use it because of the fiber optic. Now this is something which is coming up, especially in adult patients and older patients. You can come up with a retrograde nasal nasotracheal intubation. Now this is a device, this is a method technique which is now coming up, and we should use it and practice it as well. And finally, if you think that it's not possible to go with, you have limitations with the fiber optic device and other devices as well, you can straight away go with a tracheostomy and deliver anesthesia to this patient. How would you prepare him for awake nasal fiber optic? Now this is again, as I said, psychological preparation should be there. You need to tell him, discuss with him, take him consent, but these patients are very uncooperative because they are pediatric, so they will not be able to be that much cooperative. Anxiolytics obviously is, again, you could go with plus and minus, but you need to give these patients anti-sialogogue. Now here it is very important. Now, anti-sialogogue is important because you have to dry the secretions, because that itself can, when you put a fiber optic bronchoscope, it can, the secretions can obscure your vision. At the same time, the dilution can also, hamper your anesthetic, local anesthesia, because it inadvertently you need to give more drugs which can cause toxicity. So naturally, that secretion should not be there. Antiemetics for, obviously, that is one of the most important pre-medication, and nasal decongestion, because you need to decongest the nasal passage through which you go, so as to create more passage for the fiber optic to proceed. How would you obtain local anesthesia? Now, their most preferred technique is spray as you go, SAGO, or different blocks, but block is not preferred in pediatric patients, but adult patients you can go ahead with it. And sprays are in temporomandibular junction ankylosis, spray is not at all possible because the patient's mouth opening is nil. Nebulization is the best in these situations, one of the most, but it takes time, because it takes around 40-45 minutes time. So nebulization would be a good choice, but gargle is not at all a choice in these patients as well. So SAGO or spray as you go is one of the most important technique. How will you prepare and proceed with intubation? Now, as I said, this is what the DAS has come up. Stop. You can go ahead. I have already discussed on this. I'll not miss much time, but always remember, add TSP is the mnemonic which is added. So adequate explanation to the need for procedure. Decongestion is one very important thing you need to give, using vasoconstrictors like local anesthetic combined with adrenaline, or local anesthetic combined with phenylephrine could be given as a pledget in the nose, so as to act as nasal decongestion. Drying of the secretions, as I've said, topicalization, sedation should be as less as possible. And patience, you must have patience while intubating these patients. So lignocaine is the most commonly used drug. If nasal route, then obviously lignocaine with adrenaline and 2 ml of 2% lignocaine above and below the vocal cord when you go with the. Now you need to know how you go ahead with fiber optic bronchoscope. This is not the scope of this fiber optic bronchoscope is not in this discussion. So naturally, I'll not discuss in detail of that. But you have to go with the see as you go or spray as you go technique. Now nebulization, as I said, is one of the most important in method in these patients, and you can and it will be very satisfactory. And you need to also go for, especially in patients with less than 30 kilo, you can go for 5 ml of 4% xylocaine is as safe as possible. Remember that nebulization is a good choice because it causes less toxicity in these patients. So superior laryngeal nerve block, you must know this. So how do you go ahead with it? They will ask you in the question, as a question that can be asked, how do you go with it? So naturally, you need to identify the hyoid bone and then walk off inferiorly, advance through the thyroid membrane, and then you get a click, and then you instill around 2 to 3 ml of 1% xylocaine. Duration is around, it lasts around 20 to 30 minutes, naturally up to 2 hours. So you can use this technique as a block. You can go with the cricothyroid membrane identification with the transtracheal installation, because you need to paralyze the vocal cord, the lower surface of the vocal cord. So naturally, when you instill, you try to identify the cricothyroid membrane. The lower half of the cricothyroid membrane is punctured with 23 grade needle, and you aspirate to identify that space. Once you have identified, you instill 2 ml of 2%, 2 to 3 ml of 2% xylocaine. If the patient, naturally, once you instill it, the patient starts coughing, and when it coughs, naturally it goes to the carina and the lower surface of the vocal cord, which it causes paralysis. Now, this anesthesia. Now, this is very important, because then only it is possible that the tube, the patient we can sustain the tube, the endotracheal tube in the trachea. So you have to go with a transtracheal jet inflation. Transtracheal injection. Now, what problem do you anticipate while intubating with fiber optic? Now, this is very important. We have a lot of difficulties while intubating, because they have a fixed jaw deformity. Now, naturally, you cannot go with certain maneuvers which are needed while you go with the fiber optic. Distorted soft tissue anatomy could be there, and position of the larynx may be altered. And since they don't have any mouth opening, naturally they are unable to protrude the tongue. So patient cannot protrude the tongue, because at times, because of the floppy epiglottis, it can fall back on your posterior wall. So naturally, you are not being able to go for a jaw thrust by lifting the floppy epiglottis, or you cannot ask the patient to protrude his tongue, so that the floppy epiglottis can be elevated. So this is something which is very difficult when you face these patients. How would you solve your problem? Naturally, one option which could be there, either you change the patient's position laterally. You can make the patient sleep laterally. That can elevate or remove the epiglottis sitting on the posterior wall, or you can ask the patient to phonate, so that just meanwhile you try to lodge your distal component of the fibroscope right in front of the epiglottis. Once the patient phonates, probably that can elevate your epiglottis, and then you can immediately insufflate your fiber optic bronchoscope. So this is very important. These patients, very tricky, but you have to experience and practice and experience yourself. What will you do if you can encounter bleeding in the passage? Naturally, this is one of the most important contraindication. So suction through the other nostril, if it really gives you a visualize, it can obscure, you can visualize the larynx, it's good, you're lucky enough. But if it does not, you need to take out the bronchoscope totally, then wipe it, and then reinsert it. But you can change the technique overall by using a light band, as I said. What would be your technique if this patient is uncooperative? Naturally, inhalation anesthesia could be a choice, but then it's very risky and very tricky. So naturally, inhalation anesthesia could be a choice, but again, I would always keep my fingers crossed, because that is something which I would not advise or suggest in situations. So it is there mentioned in the book, so I've mentioned, but otherwise it is not a very good choice. So what other technique would you keep ready before starting? Now, this is very important. Always try to preempt and predict that this patient can go at time where you need to have a rescue strategy with you. So naturally, you have to have a cricothyroid or transtracheal jet ventilation would be the safest. And scalpel cricothyrotomy, depending upon the age group, would be always a choice. Surgical tracheostomy, before you start this patient, straight away go for surgical tracheostomy and get the case done, could be another choice. So how will you extubate? Naturally, IDA has an extubation guideline. You can follow that. You make the patient awake. Most importantly, awake the patient, complete reversal of neuromuscular blockade. And always remember, extubation is a controlled, an elective method. So always try to extubate in a controlled environment, putting a ventilating stellate, and then extubate this patient. So TMJ ankylosis patients have limited mouth opening and facial deformity, so usually associated with OSA. This leads to difficult mask ventilation, difficult laryngoscopy, and difficult intubation and difficult surgical airway as well. And awake fiber optic or emboscope is the gold standard. Fiber optic technique could be difficult because of limited mouth opening and relative large tongue. Alternative technique could be an additional, which is there. Of course, I would not always, I would not suggest and neither I recommend. Extubation should be always awake. Now, this is something which one should keep in mind. Yeah. Should we go for the burn? So naturally, this is a lady who is a 30-year-old lady presented with post-burn contracture. I'll try to be very fast in this. I'll just try to emphasize the fiber optic bronchoscope which is there. And post-burn contraction involving the face, neck, and anterior and posterior chest. She had sustained a burn injury 1 year back. Now, one very important I would like to tell the resident doctor is, since this patient is coming, ideally she's coming as a post-burn contracture, but the examiner can deviate and they can ask you something which is pertaining to acute contracture, acute burn. Now, that is why they might ask you the fluid therapy, the type of fluid, the quantity of fluid, what is the formula, the Barkland formula. They can go straight away towards that side. Or what should be the strategy of airway management at the time of acute burn, because depending upon this type of burn, whether the patient had a smoke burn, whether the patient had a black cinch sputum coming out. So these patients, when you always anticipate that the patients can have laryngeal edema subsequent to the resuscitation of this fluid of this patient with fluid within a period of 6 to 8 hours. So naturally, you preempt this patient that the patient can have a difficult airway in acute situation also. So you preempt it and intubate this patient electively. So this could be a question which could be asked to you. What should be the protocol for administration of muscle relaxants? Because naturally, this is again a very common question which is asked by the examiners. So let's go to the basic case. What are the types of post-burn contracture? What are the various degrees of burn? Now, degrees, post-burn type of post-burn contracture. You have type 1 where there is only anterior contracture. Type 2. Now, this is primarily based on the neck contracture, neck and face contracture and chest contracture. So naturally, anterior contracture is type 1. Moderate anterior contracture is type 2. And type 3 is a full flexion deformity where you have the chin is almost touching the chest. So naturally, there is no neck at all. And the type 4 is the patient which has a posterior and an anterior burn as well. And there is a fixed contracture, which is straight head contracture. Now, these are the types of type 1, type 2, type 3, and type 4. So type 3, as I said, has fixed flexion deformity, which could be there. So you don't have any neck at all. So these are most dangerous patients, even if the patient has a mouth opening. So problems are, what are the airway related anatomical changes you expect in these patients? We know this, that the patient has, one is the distorted and reduced nasal opening. Second is distorted, reduced mouth opening. Third is restricted neck movements. Fourth is stiff mandibular space, because the mandibular space will be rigid. So even if the patient has a mouth opening, you might not be able to manipulate your laryngoscope and the tongue and create an adequate space for your tube. So that could be a very difficult situation. And the scar and contractions in the front of the neck and suprasternal area, you can have a high larynx as well. So these are the problems which you can face, and the scar and the back of the neck also you can have a scar as well. So these are the problems you anticipate in this patient. What are the salient features, points to be kept in mind while doing PSC? Now, very importantly, you must keep in mind the type of surgery, whether he has come for burn contracture release. Now that it should be given priority before going for any other surgery. And release of burn contracture and skin graft should always be at time of burn. When did the patient had the burn, acute burn? So naturally, depending upon that, your drug, muscle relaxants should be always advised. Cause of burn, extent of burn, assess the airway, type of anesthesia to be administered, and starting an IV line. Now, always keep in mind that these patients can have an extensive burn where you don't have an access to the IV lines, and at the same time, monitoring of these patients could be difficult because you don't have any space to monitor. So these are the things which you have to keep in mind while doing a PSC. What are the preoperative investigations required before anesthesia? Now, these are all battery of investigations which are very important, but always remember that X-ray, neck, and AP and lateral is very important in these patients. Do we assess airway in these patients? How do you assess airway? Naturally, we have all the things which we've already discussed on this. I don't want to waste my time here. Submandibular space compliance is one thing which you always keep in mind. That means that even if the patient has mouth opening, now this is something which you always keep in mind. And at the same time, placement of supraglottic airway device could always be a difficult, especially in fixed flexion deformity, even if the patient is mouth opening. Because there is a study in Ishimura which we said that if the angle between the oropharynx and the laryngopharynx is less than 90, you'll always have a difficult in placement. So that they are the things which you always keep in mind. What are the various stages where you can face difficulty in airway management? Now you know this. These are all which I've already discussed. From all the stages, you'll have face difficulty in this patient. Provided to certain extent, what you might not face difficulty is putting a supraglottic airway device, keeping in mind the patient has a mouth opening and intubation also, but you always remember the patient does not have any neck extension or flexion. So naturally, this is also not an easy job. So what are the different options of airway management? I try to, make it a sort of an algorithm format, whatever options we have. So first is gold standard is that patient can go straight away with awake fiber optic intubation. That's the first thing, first choice. Now, depending upon the mouth opening, you can have two fingers, more than two fingers mouth opening the patient has. And if you don't need a definitive airway, then you can go for supraglottic airway device intubation, or you can go for wide video laryngoscope aided intubation if the patient has a mouth opening more than two fingers. Now, if you need a definitive airway, then, and if the patient has a more than two fingers and the patient does not need a definitive airway, we can straight away go with the supraglottic airway device and carry on the case. But if the patient has a less than two fingers and definitive airway not needed, combi tube and laryngeal tube suction could be a choice, which is there. But if you think that the patient has a definitive needs a definitive airway, you can go with a fiber optic airway. Now this is again a gold standard. So this is what I try to enumerate. The other thing is, if you think that you don't have any other, you have very limited resources and there's limitations, you can straight away go for release of scar incision with ketamine, and then you can go for intubation or supraglottic airway device insertion. And the fourth technique which is there in the book, and very old technique which has been used by many people before, was the tumescent anesthesia. I'll try to let you know in short. How would you prepare him for awake nasal? We have already discussed this. How would you obtain local anesthesia? We have already discussed this. But one thing is, with the fiber optic bronchoscope, always keep in mind that you need to know how you use a fiber optic. How do you use to paralyze these patients with the help of a local anesthetic installation of local anesthetic. Now, local anesthesia for awake fiber optic intubation are, now this is something which is being very pet question of the examiners. Now, 20 to 30 sprays. Now, what is the content in each spray? That is very important. You are giving 10% spray to this patient. Now, what does each spray contain? Now, this is what I tried to mention here. One spray is equals to 0.1 ml of 10%, which means that is one spray is equal to 10 milligram. So naturally, 20 spray or 30 spray will be accordingly 200 to 300 milligram. Why do you need to know this? Very importantly, you need to know this because the total amount of drug which you will give to this patient, local anesthetic, should not exceed 9 milligram per kilo body weight. So you need to know the total dose which you are giving to this patient, and at the same time, if 1 ml of 2%, if you're giving 2% of lignocaine, 1 ml is 20 milligram. So naturally, again, you calculate the dose overall, and accordingly, you give your spray and your drug. Right. Internal laryngeal nerve blocks. So these are all blocks which are there. I think I would advise you to go through the books and find it. Now, when you use a fiber optic, certain tips I would like to give you here, because they can be asked in the examiner. One is, you stand tall, and you should be, the fiber optic bronchoscope should be as straight as possible. Now, there are 3 maneuvers, right, which you should know. One is jaw thrust, one is the other is protrusion of tongue, and the third is phonation. Now, these 3 maneuvers you should always keep in mind, and 3 most important steps in the technique. One is stand tall. Second is you hold you fix your fingers over the patient's angle of the mouth or nose, and you try to hold with the help of the 2 fingers, the thumb and the index finger, you negotiate this. So this is in short what I thought. I'll just try to cover it up. And you need to know the 3 zones. So 3 techniques, 3 maneuvers, 3 steps, and 3 zones. Always rule of 3 you should keep in mind. 3 zones one is the white zone, the second is the pink or the red zone, and the third is the black zone. Always remember, you need to follow or trace the black zone. The white zone is the mucous membrane. The pink zone is when it is the glow of the underlying tissues, and the black zone is the hollow space through which you have to proceed with your fiber optic bronchoscope. And you need to know all the structures before you pass your fiber optic bronchoscope, where you are going. So these are the things. This is something I just thought of telling you, the troubleshooting when with the fiber optic. So if you can't find the larynx is displaced, go for a jaw thrust, tongue protrusion, and use direct laryngoscopy as well if you need. And if you think that the epiglottis is floppy, which is sitting on it on the posterior wall, you can ask the patient to sit up. Okay, or you can place the patient in lateral position, or you can ask the patient to phonate as well. If you see elevated posterior larynx, so go around the edge of the large floppy epiglottis and try to find out, insinuate your fiber optic bronchoscope. You cannot identify the larynx, so landmarks is distorted. You ask the patient to vocalize, as I said. Bubbles coming through this, that can also help you out. If you can't reload your endotracheal tube. Now, this is a very catchy situation. Most of the time you have this problem. You're not being able to railroad your fiber optic, your endotracheal tube. Always remember that endotracheal intubation is not under revision in fiber optic. This is a very common question which is being asked by the examiner. Do you think that in fiber optic intubation, can you see the tube passing through your vocal cord? Now, that is not possible. You cannot see that. So that is why you are always getting catched. You're getting a problem while you're passing an endotracheal tube. One very important thing is, while you're passing an endotracheal tube, ask your assistant to maintain the jaw thrust, or let the patient go on with the phonation or protruding of tongue so that the epiglottis is lifted up. Secondly, if you have really the edge of the tube is being catching, because at times if your fiber optic bronchoscope is not at par with the endotracheal tube, because if you have a more space between the fiber optic bronchoscope and the endotracheal tube, there is always a possibility that it can get catch over the vocal cord. So you need to have a snugly fit endotracheal tube over the fiber optic bronchoscope. But if you think that it is getting catch, you can rotate your endotracheal tube to a 90-degree posterior, and you then can slide your endotracheal tube through your fiber optic bronchoscope. Now, that is what you can there are certain tubes which are known as SPARC's tube, which is a parrot beak tube. They are snugly fitted over the fiber optic bronchoscope, and it prevents your getting catch up in the vocal cord. So at times you can also have you cannot remove the endotracheal tube, or you cannot remove the fiber optic bronchoscope. Now, these are the situations which you can face. Now, you have to either take out the whole of the bronchoscope and the tube at all, or you need to most importantly you can remove the scope along with the endotracheal tube and reintubate over a wire again. So these are some of the tips which I thought I will let you know. And finally, what is tumescent anesthesia? Now, this is a pet question of the older examiners. They ask you what is tumescent. It is primarily tumescent means swelling. Always remember, it's a very common term which is used for swelling. You go for a mixture of 2 ml of lignocaine, 1 milligram of epinephrine of 1:1000, 1 ml of hyaluronidase containing of 1500 ml of international unit, and 450 ml of Ringer's lactate. Now, you make a mixture of this. Use this 70 to 200 ml of this mixture. This primarily what it does, it separates the tissues and the scar tissue, and it creates a space over which the surgeons can then they can go for dissecting the scar very easily, and at the same time they can have an anesthetic effect as well. So this is what used to be used once upon a time, but it's not. It's almost obsolete nowadays. So, this is some question which the patient can be asked. Very importantly, why the non-depressing muscle relaxants are resistant to in cases of bun contracture? Because most importantly, that the neuromuscular junction, the acetylcholine junctions, they are being tight fitted and they're being kept in place by the help of a protein known as rhabsin. Now, this rhabsin it gets dissolved, or it gets burnt out. So naturally, what happens? The neuromuscular junction gets proliferation. There is a proliferation of the receptors of the acetylcholine receptors to other areas, and naturally the volume of the receptors increases, and you are not being able to whatever dose is required in this patient then probably you need an extra amount of dose to paralyze this patient. And this takes place starting from 1 week to around 18 months. And but one very important thing is this only takes place when more than 30% of the total burn surface area is there. So if it is less than 30%, around 10 to 20%, you'll not have this problem. Probably the muscle relaxants which has been given is almost the normal. But in cases which is more than 30%, you need to give an extra dose. Now, what very important thing is mivacurium does not have this problem, but succinylcholine has an additional problem. Succinylcholine is importantly is that it liberates the, it generates potassium. So naturally, it can go up to an extent of 13 milliequivalent per liter of while injecting succinylcholine. So there's always a possibility that these patients can go with a ventricular fibrillation and cardiac arrest. So you need to know when the patient has sustained burn contracture. Depending upon the time and duration and the extent of burn, you need to taper your succinylcholine. And most importantly, some book states 2 to 3 months, but nowadays the dictum is that you need to wait for 2 years. You should not use this succinylcholine. It can cause disaster. So tube fixation could be a problem. You use, you can suture the gums or the tooth, or soft sealing ribbon can be used. And monitoring is, again, I have already discussed, but you always keep in mind that you might have to go for an invasive blood pressure monitoring in addition to the non-invasive. And extubation guideline should always be followed while extubating this patient. This is what the IDA extubation guideline looks like, which will be dealt by my subsequent speaker. And so the key points are extent of burn and degree of burn is very important. Type of contracture, as I said, fixed flexion deformity or straight head deformity is there. Changes in drug metabolism, muscle relaxants, you must know because there's a pet question for the examiners. Difficulties in airway management, all the difficulties you must know, the mnemonics. Administration of local anesthetics, the dose of the drug, and each ml of drug, how much it contains. That is very important. What the techniques, they will ask you. Techniques of airway fiber optic intubation and supraglottic airway device and tumescent anesthesia can be asked by some of the examiners. And extubation is always an elective system. Thank you so much. Best of luck for your exam.